Thank you, first of all, to K-Corp, Dasra, and everyone for having me. I know that we've been hearing a lot about Maharashtra so far, but I'd like to sort of move geographies a little bit and talk about a geography where Khushi Baby first started, which is Udaipur in Rajasthan. So if you search for Udaipur on your phones, flooded with images of the Venice of the East, shimmering waters of Lake Pichola, white marble from the city palace, and many luxury resorts and hotels that are consistently ranked amongst the best in the world. This is the Udaipur of the postcard, a symbol of heritage and hospitality around the globe. But there's also another Udaipur. If you drive just an hour and a half away from those marble palaces, the roads become narrower, you're rising in the Aravali hills in rugged and hilly terrain, and the luxury of the Udaipur city disappears, and poverty and poor health begin raising their head. And it is in this remote part of the Udaipur geography, in a village called Murela, that's nestled on a small hill in Salumbar district, there's a family that's residing there that is grappling with poverty and adverse social norms. Ravina is a young child in this family. She lives in a katra house made of grass and mud. Her father is a truck driver, and her mother is a homemaker. Ravina has two older sisters, and her family, like many others across the nation, also suffer from male preference that leads to neglected health for the girl child. So in March 2023, Khushi Baby's field monitor, Mahendra, learned about Ravina from a local ASHA worker when he was making a visit to the village. Ravina's condition was frail. Her weight was alarmingly low. Her mid-upper arm circumference was less than 13 centimeters. All clear signs of acute malnutrition. Mahendra advised the family to take Ravina to the nearest hospital as soon as possible for evaluation and treatment. But convincing the family to go to care was more challenging than he initially thought. Ravina's father dismissed the suggestion. He didn't believe that medical intervention was necessary to treat Ravina's condition, and her mother remained silent. Mahendra promised to visit them again and encouraged them to prioritize Ravina's health and make a visit to the hospital as soon as possible. When Mahendra returned in April, Ravina's condition was the same. When he asked the family whether they had taken her to the hospital or not, her father revealed that he had instead gone to a local quack. The quack had removed worms from Ravina's ears, or claimed to do so, and had promised the family that she would make a full recovery. Mahendra realized that the situation was extremely grave. He tried to counsel the parents and tell them about the importance of getting professional medical care. He explained that Ravina's symptoms might indicate digestive or systemic issues. Due to Mahendra's persistent efforts, Ravina's father reluctantly agreed to take her to the district hospital in Salumbar. Mahendra visited Ravina's family again in August, and this time there was a significant improvement in her health. Following the hospital visit, Ravina's nutritional status had improved, she had gained weight, and she exhibited noticeable physical and behavioral improvement. He commended the family's efforts and emphasized that in order to prevent a relapse, vigilance and sustained care was necessary. Ravina's journey underscores the challenges faced by families in similar geographies across Rajasthan and India. High-risk cases are regularly identified by governments and by ASHA workers on the ground. However, care pathways are often not completed. Hard-to-reach areas, cultural and gender norms, limited access to healthcare, and poverty impede timely medical intervention for many Ravinas across the country. This is one example of 8,000 such high-risk cases that Khushi Baby field monitors tracked in Rajasthan over a period of time and referred to the health system. However, the scale of this problem is much bigger than just 8,000. According to the National Family Health Survey in 2020 and 21, 7.7 children under the age of 5 in India were found to be severely wasted. This translates to approximately 10.5 million SAM children worldwide. I'm sure people in this room don't need sort of more impetus to solve this problem, but clearly the scale of the problem is extremely vast. Severe wasting, especially in the critical 1,000-day period, has far-reaching and long-term consequences. It is a silent killer. a child suffering from SAM is 9 times more likely to die than a healthy peer. In the first 2 years of life, when the immune system is still learning, this malnutrition acts as a catastrophic gateway, turning common treatable illnesses like pneumonia and diarrhea into fatal events for roughly 1 in 10 children affected globally. It also imposes a 22% wage tax. The damage of SAM is not just physical or not just in the first 1,000 days. It is also economic and long-term. Children who survive wasting in the first 1,000 days are likely to experience permanent cognitive stunting, resulting in a loss of 22% of their lifetime adult earnings. By the time they enter the workforce, they are already at a structural disadvantage and locked into a cycle of poverty. It is also a national productivity drain. Beyond individuals, SAM is a macroeconomic anchor. It is estimated that aggregate impact of early childhood malnutrition costs the global economy $3.5 trillion annually. For a country like India, the millions of SAM children that we see represent a human capital leak. They are the future doctors, engineers, teachers, and health workers who are hindered by the biological damage sustained even before they enter preschool. The infrastructure to save these children already exists. We have the Poshan Tracker that we've heard about already, a massive digital census that is intended to track SAM children and identify them in real time. We have the 50-year-old ICDS scheme, a social safety net that's designed to put calories directly into the hands of the most vulnerable. And we have frontline workers, the foot soldiers of health, who work to reach the last mile and counsel every household. But here is the structural tragedy. This is not a single unified force. They exist in fragmented silos. The data in the tracker doesn't always trigger referrals and home visits by the frontline workers. And the home visits don't always guarantee that the child will get admitted to a hospital or get the care that they need. We are essentially operating with a broken relay race. And the baton is getting dropped between identification and treatment. What is missing is a convergent system that closes this loop. Measuring malnutrition is not enough. The system cannot solve for what it cannot track to completion. It is this miscare loop that we set out to address in Udaipur. There, we were able to close this loop of care by placing our field monitors on the ground. They identified high-risk children from the data that they obtained from Khushi Baby's CHIP platform or through insights provided by local frontline health workers. They conducted home visits to monitor the progress of each case and to counsel parents about the urgency of care. They also facilitated transport in hard-to-reach areas to hospitals and healthcare facilities and accompanied parents to these visits where needed, in order to ensure the loop of care was closed. Our work in Rajasthan led to the recovery of over 8,000 children, which is about 50% of the identified SAM children in the system. This model was also applied to track high-risk pregnancies, tuberculosis patients, and zero-dose immunization cases. However, we soon realized that to tackle this problem at the scale it currently exists, which is 10 million children under 5, this standalone model cannot work. In Udaipur, we learned a hard truth. We were building a parallel architecture. While we reached over 8,000 children, we were operating outside the system, not as a part of its gears. This created a fragility of impact. If tomorrow Khushi Baby exited, the care pathway for these children would also disappear. We realized that to reach millions of children, this NGO-led model cannot work. It needs to be institutionally embedded. Sustainability can only be guaranteed if the system owns the solution. We didn't just need the government's permission to work, we needed their ownership. Which brings me to Nandurbar, which you've already heard a lot about today. We began working with the Nandurbar district administration to bring our lessons on SAM tracking and malnutrition to Maharashtra. Nandurbar, like Udaipur, is a remote district with a significant tribal population. Many families migrate seasonally for economic opportunity to the nearby hub of Surat or even further. Hilly terrain, poor road connectivity lead to similar challenges in getting identified high-risk cases to health centers and hospitals in time for life-saving care. It is in that 100,000-day critical period that pregnant women, high-risk pregnant women, malnourished children, and children born with birth complications are falling through the cracks in Nandurbar. But what is different in Nandurbar is that we have a government official championing our model in the form of Dr. Mitali Sethi, you just heard from earlier in the day. So in Nandurbar, we have set up a government-owned and embedded call and action center within the district administration building, staffed by nurses and public health experts who are connecting with potential high-risk cases on the phone. Over phone calls, our Health Action Center staff call high-risk pregnancy cases and caregivers of high-risk children. They counsel them about the need for follow-up care. They escalate cases where the families are not willing to comply. Each high-risk case is tracked by the Health Action Center at every step of the care loop. Initial assessment, referral to an appropriate facility, completion of follow-up visits, and hospital admission when necessary. And finally, recovery. We are taking fragmented data sources, hospital records, government administrative data, data from our own platforms, like CHIP, to identify high-risk children. We then turn that data into actionable insights in the form of linelets of high-risk patients with their identified underlying condition. Finally, through our calling and escalation systems, we're supporting frontline workers and health officials in targeting their efforts through effective action to connect these high-risk children to care and recovery. Our goal in Nandurbar is to develop a scalable model that can be replicated to similar aspirational, marginalized and tribal districts across the country. Over the next 3 years, we aim to screen over 3 lakh pregnant women and children for high-risk conditions, track over 39,000 such high-risk cases, and close the loop of care and recovery for 22,000 such cases in Nandurbar. And we truly believe, if successful, this model can be an example not just for Nandurbar or for Maharashtra, but for aspirational districts across the country and for geographies beyond India as well.
We can open the floor for a couple of questions. So if anybody has any questions, please feel free to ask.
These models can be very actionable, can be done in a one block, one district, because these are very dependent on the will of the administrator, right? We have seen the administrator, fantastic administrator in front of us. But when we go into the kind of a scale, unless until it has a link with the portion tracker at this moment in the country, it will not work if we even replicate. So do you see any possibility or anything you have tried on that?
I think that's an excellent question, and I can talk about something we are trying to do in that area. So I didn't get a chance to go into the details, but we have a program that we're working on with the Department of WCD in Maharashtra called Nurture, which is trying to fill exactly this gap that you were talking about. Portion tracker is identifying where are the SAM children, what are their weights currently. We've built a module called Nurture, which then sort of tracks the child from that point to a reassessment and then referral to, let's say, the NRC or the VCDC, whatever is the appropriate form of care, and then looking at whether they're completing that entire round of care or not. So sort of gathering data, but also sort of triggering action on the part of the community health worker to close this loop of care. That's an ongoing program. I think a lot of our members of the Nurture team are actually here, and I can ask them to sort of add to this. But we're sort of trying to see what the results from this are going to be.
So I think that's the whole approach that what we are trying to. So when we are saying data, so there is a D, there is a I, and there is a A. So when we are saying data, so we are trying to have the data agnostic system, which means data is not we are going to digitize everything. So the portion tracker, as you asked, the portion tracker already exists, where we are identifying the SAM children. But the limitation with the portion tracker is the further tracking of the SAM children is missing currently. So what we did is we bring the Nurture, what Urvashi was just talking about, so that the end-to-end tracking of the SAM children should be feasible. So like for example, after SAM children, few children is going to the NRC, few is going to the VCDC, and few can recover at the home itself. So based on this system, the next the alphabet is I. What the kind of insight we are generating is, okay, the ICDS supervisor or the Anganwadi worker have referred these children to the NRC, but whether that children has reached to the NRC or not, because that is the lot of referral loop is not closing currently. So that kind of insight we are generating. Now the Health Action Center, which Urvashi is talking about, is now connecting with every family, every Anganwadi worker, every ICDS supervisor to ensure and the NRCs collate those children so that the loop of the referral should be closed, and that's the action that what we are aiming. And the final is the outcome we are seeing, that whether this referral loop is closing, whether they are getting treatment. So that's how we are trying to build the DIA loop on the existing data system, not just building a new solution.
If you have severe malaria, so they don't record it at all. The Anganwadi worker fears that if she records, she will be taken to task. How are you handling that issue? How do you handle whether Poshan tracker is entering data correctly or not? Leave alone SAM, otherwise also. Is it arithmetic which is working, or is she really tracking the weight?
Ma'am, I'll also add one more question to the same thing. One is tracking and having the data. The second is about not just referring to NRC, but completing the course and follow up after that. So some small study done in NIN with Telangana NRC children, post 6 months, 3 months, 6 months and 12 months have shown different things. I mean, does the Health in Action team stop at referring them to NRC, or goes beyond completing the NRC course and follows up after that?
The answer to your question is yes. The Health and Action Center is exactly to do this, is to follow up after the NRC discharge happens. So we will be making calls to the beneficiaries themselves as well as to the frontline workers to make sure to, one, check the status of the child post-discharge, and if they need to be readmitted, following up on that readmission. So that's also a point that we're trying to close. To ma'am's question about data, we completely agree. I think that's what we've learned in rolling out Nurture so far, is that Poshan tracker data itself is undercounting SAM children. And then once we do the reassessments, there's a lot of discrepancy between that reassessment data versus Poshan tracker data. So we are certainly trying to sort of work with the government to solve this problem. I think it requires a solution that is sort of beyond the Nurture technical solution, but it's more of a governance solution that is needed in terms of actually, like Mitali ma'am said, encouraging people to report SAM rather than punishing them because they report higher numbers. So it's not a technological solution, but a different solution we would be advocating them for.
Just to supplement what what has been said, I represent Rajamata Jizo mission in government of Maharashtra. ICDS Poshan tracker data in Maharashtra is concerned. The volume is fair. There are some discrepancies. I do agree with that, but that is, as Urvashi has mentioned, the Nurture gives an opportunity to confirmatory assessment of the whatever the data fetched from the Poshan tracker to Nurture by APIs, real time. So that is one more opportunity given in this Nurture. So that gives an opportunity. And wherever, during the course of earlier discussion, it was said that when the SAMs, the stress is there, SAMs are decreased. The SAMs are, intentionally declined, then the stunting gets increased. So all these are being tracked, where it is happening and how. And then joint screening is one more, this thing, the GR of which I was just seeing. The government of Maharashtra, Nandurbar is the pioneer in, treating this as a joint screening as an endeavor in Maharashtra, just to validate the mishaps and the ill things of that. And they have, in spite of a small districts, they have shown up, guts to execute the exact number of SAM children over a period of that. And the state has taken pride to roll out this practice in whole of the Maharashtra. That is one thing. And the GR is under issuance.
Thank you. But I would request Urvashi to please stay back. I would request Mr. Mohammed also to come, and Shrutika to please hand over the token of appreciation to the Kushi Baby team.